Well, good afternoon out there, everyone. Dr. Tony Brown here, coming to you with another edition of Clinical Pearls and Profits. All right, guys, so we had a couple of requests over the last several weeks, so I thought it was a really good idea. Lots of practitioners wanted to go through the lab panels one by one by one, right? Talk about um, reasons and indications that one might order such lab panels, some of the differential diagnoses for those. So that's what we'll do. We will spend, just giving an idea of what's coming over the next several weeks, uh, this series, if you will, going over each and every popular lab will probably take us about 2.5 months. Right, it's about 10 hours. Oh, I'm sorry, wait a minute. About 6 months because this is about 10 hours worth of stuff and we only spend about a half hour together. We will interrupt that with a couple of sessions that will be performed by Virtual MD, right? This is Virtual Clinic. However, we will have Virtual MD do a couple of guest spots because you'll find that they are developing quite a line of services that you guys will probably be interested in. For instance, $69 a month for a lifetime membership where you get a crazy number of blood panels drawn and some physicals and all kind of good little stuff. But I'll stay in my lane and let them do them. So you'll hear them come on a couple of times. It is a sister company of Virtual Clinic, and I'll be excited to hear it all myself too. Okay, so why don't we get started? Let's talk about some glucose. All right. With regards to glucose, okay, so a common reference range that we look at when we're talking about glucose, and keep in mind, there's a couple of different kinds. There's the fasting glucose, right? And then there's your plasma glucose. So we're going to talk about just plain old reference range of your plasma glucose right now, 65 to 99 milligrams per deciliter. With regards to the um, units, right? Yes, there should always be a unit. But unless you're dealing internationally, you can feel comfortable that you are probably talking about the same units as the next person. But that said, you don't want to ignore units. So for instance, here we deal in milligrams per deciliter. Internationally, we deal in millimolars per liter. That can really change your numbers. Um, However, you really don't have to worry about it because once you are dealing in the same program in the same country, it's going to be the same units, right? So we at Virtual Clinic, for instance, are going to deal in milligrams per deciliter. All right, so let's talk more about it. So, where do we get our glucose? It is formed by digesting carbs. Okay, so the carbs are something that's in your diet. Once you metabolize those carbs, the body takes them, turns them into energy. Sends it to a couple of different places, of course. Going to send some of it to the brain primarily because the brain loves glucose. Um, it'll also send some of it to the muscles. It'll send glucose to other organs, and then whatever is not used gets stored as fat. As a matter of fact, the body really only uses about 1,500 to 2,000 calories of glucose when it metabolizes it. The rest of it is just going to be turned into some nice, juicy fat. Um, Glucose is the primary source of energy for most cells. Insulin glucagon, thyroid hormones, liver enzymes, and adrenal hormones regulated. What did we just say? We just said that if you have a patient, guys, that comes in, and this patient is, let's say, borderline diabetic after you do a fasting glucose on them. Let's say that this patient has high levels of hemoglobin A1C. Then your next step is not just checking the glucose, but to look at everything that is surrounding it. This indeed is the justification that you give to your patients when you want to do a much more comprehensive blood panel analysis than they are used to from their traditional doctors. Yes, I need to look at your insulin because that's what's going to regulate the reduction of your glucose. Yes, I need to look at your glucagon because more glucagon, more glucose. Who knows? Is there a glucagon producing tumor floating around somewhere? Yes, I need to look at your thyroid hormone because there is a direct relationship between thyroid imbalance and glucose imbalance. Yes, I need to look at your liver enzymes because things like hepatitis and alcohol will affect your liver's ability to do its job, specifically to make proteins. Which proteins? Enzymes that will regulate your glucose levels. And yes, I need to take a look at your adrenal hormones because your adrenal gland is going to be that organ in your body which, when nothing else is going to produce energy, your adrenal glands are going to say, hey, I'm under a little stress here. I am going to produce some stress hormone. I'm going to produce epinephrine, norepinephrine, cortisol. And if I, the adrenal gland, do it too long, I'm going to have adrenal fatigue. Okay, so these are the reasons that you give your patient for, you know, measuring more than just one thing um, with a blood panel. To move on down to the next bullet, low levels of glucose may be indicative of liver disease, overproduction of insulin, and insulinoma, right? Hypothyroidism. And keep in mind, right, the relationship between insulin and thyroid is that basically your T3, T4, you look at that as jet fuel. When your body needs a little bit of extra boost, the thyroid hormone is one of the very few substances that has a receptor on each and every single solitary cell in the body. In other words, when your body needs to turn up the volume on those cells, it does it so by increasing the production of T3. Okay, it's one of the reasons when you have a patient, for instance, that comes in and let's say that they are on a ketogenic diet, which is to say they are taking in less or fewer carbohydrates. What you're going to find when you take their labs is as their carbohydrate levels go down, their glucose levels go down, and then their T3 levels should also go down. We'll talk about that later. Um, Alcoholism is also something, as we've already mentioned, that affects gluconeogenesis. Glucose is elevated in diabetes, as you know, and you know what? Let's say that in a more universal way. When you look at diabetes, when you're concerned about kidney pathology, when you're concerned about end organ damage, when you're concerned about hyalization of the efferent arteriole, when you are concerned about hyalization of the afferent arteriole and hemoglobin A1C and extra aldol reductase in the lens of the eyeball, which is why your patient keeps having to get new glasses every 6 months. Looking at all of this stuff, the one overwhelming substance in this universe that causes all of these. I haven't even mentioned silent heart attacks, neuropathy, gangrene of the extremities. All of this stuff, guys. Glucose, 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 glucose. It is the thing that causes, without exception, all of the problems of diabetes. Okay, you give me a problem in diabetes, I'll give you a mechanism to connect glucose to it. Okay, so not only is it elevated in diabetes, it's elevated in liver disease. Well, I'm sorry, I shouldn't say elevate. It is involved in liver disease, obesity, right? We just said your body can only store 1,500 to 2,000 calories. Therefore, whatever it does not store, whatever it does not use immediately, it will just store it as fat. Pancreatitis, steroids, right? Because steroids are gluconeogenic. In other words, you know that weightlifter is going to take steroids so they can increase those muscles between their fingers and be really manly like, right? And what are the steroids going to do? Those steroids are going to be gluconeogenic so that they can create more energy to create more amino acids, to create more proteins, to create more muscle, right? Stress, right? Stress hormones. Uh, we've already talked about the fact that epinephrine and norepinephrine, cortisol are considered stress hormones. Well, so is glucose and glucagon. In other words, when the body thinks that it's going to be starved for nutrients and micronutrients, then it's going to start creating the stuff that it can. Diet can increase your glucose levels. We know that. Um, that's just called bad eating, and we'll get into that a little bit later. All right, let's talk about blood urea nitrogen, aka BUN. So, reference range 5 to 26 milligrams per deciliter, internationally 1.8 to 9.3 millimoles per liter. Your BUN is a byproduct of the breakdown of proteins. Let's be more specific. Muscle tissue, right? So when you break down, the body makes 20 times more acid than it does base. When it's just going through its daily activities willy-nilly, minding its own business, it will make 20 times the amount of acid than it does base. Therefore, one of the main duties of the body to remain in balance is to make sure that it makes a lot more base. We'll talk about how it does that a little later. For the purposes of this particular part of the conversation, one of the ways it makes so much acid is breaking down muscles into proteins, into amino acids. Okay, so therefore, low levels of BUN may be indicative of low levels of food intake, which may lead to the body breaking down muscle tissue, therefore causing weakness. And by the way, the proximal convoluted tubule of the kidney hates to be touched by broken down muscle. It will be damaged. It is exceedingly, exquisitely sensitive to some things. One of those things are acidic components like this. You can use BUN levels to point out severe liver insufficiency, over hydration, especially decreased protein intake. And then increased BUN may be indicative of an impaired renal function, right? You're going to have patients that come in, and you can have one of three problems with the kidney. You can have a pre-renal problem, a renal problem, or a post-renal problem. And it's really cool to look at the numbers when you're looking at your BUN, and you can basically look at the ratio between um, the creatinine and BUN. You can look at the ratio between those and figure out where the problem is before the kidney, in the kidney, or after the kidney. I think it's pretty cool. Increased levels may be indicative of impaired renal function, congestive heart failure, right? CHF, everybody remembers that. Right-sided signs, left-sided symptoms. Your patient's going to stroll in. If they have right-sided signs, That means they're going to have things like collection of fluid in the extremities, right? They're going to have edema, right-sided signs. Maybe their head bobs back and forth when they're just sitting there letting their heart beat. Maybe they've got jugular venous distension. Left-sided symptoms, which by the way are going to come first. Why? Because right-sided signs, what I mean when I say right-sided signs is that right-sided heart failure carries with it signs that are visible by the clinician. Left-sided symptoms are things that are experienced by the patient. Left-sided heart failure symptoms are, for instance, hey doc, the only way I can sleep at night is by putting 3 pillows beneath my back because I need to sit up. Every time I lay down and try to go to sleep, I feel like I can't breathe. That's called pillow orthopnea, right? And you'll write that in your SOAP note. 1 pillow orthopnea, 2 pillow orthopnea, 3 pillow orthopnea. They'll also tell you, doc, I gotta somewhere around 2 or 3 in the morning. I got to get up and go to the window because and open up the window and just stand there and breathe because I feel like I can't breathe. Okay, remember, you know it. The most common cause of right-sided heart failure is what? Left-sided heart failure. What did I just say? You have every reason to chase down left-sided heart failure and resolve that thing before it progresses into right-sided heart failure. With regard to left-sided heart failure, one of the problems you're going to find is a decreased cardiac output. A decreased cardiac output. You guys know the deal. How do I figure my cardiac output? Stroke volume equals heart rate. In other words, either my heart is not beating fast enough, that's heart rate, or it's just not pumping out enough liquid, that's stroke volume. If I take a look at the stroke volume, there's many reasons that could be decreased. And one of the ways I measure a decreased stroke volume is my blood urea nitrogen. Okay. Once we do creatinine, I will take a look at both of them together and then talk about the ratio between the two. You can also affect your BUN by a high protein diet. Why? It's because of what we just said. The proximal convoluted tubule of the kidney hates broken down muscle. So if you eat a lot of protein for whatever reason, weightlifting, you want to gain weight, you're on some strange new diet, just realize this is not without consequence, right? And then there are drugs that are also nephrotoxic. That would be corticosteroids and tetracycline, right? Got somebody with a bite from a deer tick and they walk back in with a target bullseye on their leg, excuse me, and get a prescription of tetracycline. You also need to monitor their kidney function. Okay, so there you go. Let's talk about creatinine. All right, so with regards to creatinine, reference range is 0.6 to 1.5. Now, it is a waste product of, here we go again, muscle metabolism. Its level is a reflection of your body's muscle mass, right? So in other words, if the levels of creatinine are low, then that implies that you're not getting enough food, protein starvation, right? Liver disease. Why? Because it's the liver that's responsible for making proteins. But if your liver is broken, you're not making proteins, then your creatinine level, which is based on proteins, goes down. Elevated levels of creatinine. Why are those seen? Well, they're seen in kidney disease, muscle degeneration, and then some drugs that inclined to impair the function. Now, I just mentioned I was going to talk about creatinine and BUN together. So here's the deal, guys. When you have a patient that goes into some major surgery, right? When they come out and they go into their hospital room, when you round on them the next day, what's one of the top three things that you're looking for? Kidney function. Why? Because we know as clinicians that a decreasing kidney function is a harbinger. It is a sign. It is a yellow sparrow for impending bad news, right? In other words, when the body starts to shut down, one of the earliest organs that do so is going to be the kidney. How do we know the kidney is starting to shut down? Well, one of the ways we do is we look at the output, right? Input, output. How much is your patient taking in versus how much are they peeing out in that little bag on the side of the bed? Another way is this idea of creatinine and BUN. So they both operate on the same principle, and I want you to think about it like this. There's this concept called glomerular filtration rate. In other words, how fast does fluid move through your kidney glomerulus? You got like 1 million of these glomeruli in your kidney. How fast does liquid get drained out of them? It's about 100 milliliters a minute, but nobody cares. So at 100 milliliters a minute, if that's what's coming out, then you know you've got a healthy kidney. It's filtering 100 milliliters per minute of liquid. Yay, Bill. Now, if it is filtering less, what's going to happen is that you have increased levels of creatinine BUN. I know that is counterintuitive. So I want you to think about it like this. Think about the GFR, the glomerular filtration rate. There's a river running by you, right? It's the river that was filtered out of the kidney. And you're sitting on the side of the banks, right? You got a little picnic basket and a glass of cold tea and a ham sandwich, and you're just minding your own business and you are fishing. Your fishing pole, you dip it into the water to catch some fish. The fish you're catching are BUN and creatinine. Now let's think about that. If I've got a really fast moving river and I dip my fishing pole in there, how many BUN creatinine fish am I going to get? Not very many, because they're moving so very fast past my fishing pole, past my filter. Okay. A fast moving GFR is a healthy kidney, which means you're not going to be able to reabsorb or catch many BUN. And the other one's the other one. A slow moving river, a decreased GFR, 50 milliliters per minute. What's going to happen with a slow moving river when I dip in my fishing pole? Man, I got all day long. I can dip in the pole, catch a few fish, take it out, take a bite of my sandwich, put the pole back in, catch some more fish, because the fish are coming by so slowly now. I got all day long to catch them. In other words, a low GFR is a slow moving river, which gives me more time to catch, that is to say, reabsorb my creatinine and BUN fish. What did I just say? Decreased GFR means an increased creatinine BUN, means bad things are happening. Okay, so that's how I encourage you to think about it. Let's go ahead and look at one more thing. It'll be the last topic for the day. Um, there are some drugs that are involved in the impairment of this function. And sometimes you want to affect your patient's kidney function purposefully. What do? I know you do. I know you do. When a patient walks into your door and you realize that they're a diabetic, right? And you looked at their GFR in January of the year 2000 and they had a 100, and they came back in 5 years later and you notice that they had an increased GFR. By the way, just because it went up doesn't mean it's good. They had an increased GFR. Well, they had an increased GFR because they got all this gook that's starting to build around their efferent arteriole, that the part of the water hose that leads out of the glomerulus. It gets stopped up. So you get all this water backed up into the glomerulus and being squeezed out as GFR into that river. In that particular case, a high GFR is bad news because it tells you that the rest of the system, it's kind of narrow and you can't even fit a lot of water through there. What do? Right? You give them a medication that is going to relax that water hose, and instead of it being forced out into that fast moving river, it relaxes that water hole called an ACE inhibitor, right? Or a ARB, an angiotensin receptor blocker. You give them that so that you can allow the fluid to move through their kidneys at a more natural rate instead of backing up and being squeezed out as GFR. So, this is an example of you're purposefully manipulating a patient's GFR in their kidney with a drug. But you got to tell them, dude, I can help you out and keep off and keep away from end organ damage. But this is only going to last so long. This drug will help you out temporarily, but I promise you it will fail. What you got to do between now and then is adjust your lifestyle. Because if you don't, the day is coming, and it is not far, when there won't be a drug that can help you. This is what you have to tell them. This is why when that diabetic patient comes in, I just gave you more reasons to check not only their kidney function, check their BUN, check their creatinine, check their liver enzymes, right? The body does not work in a vacuum. You want to be able to do a much more comprehensive blood panel on those patients, give them the rest of the story, as they used to say on that old radio show, and hopefully everybody is happy. You did it one more time. You wasted an entire half hour with me nerding out about science. So, guys, if you got any questions, you can shoot them to me on email. I'll make sure I don't have any questions here right now. And otherwise, I will see you same bad time, same bad channel about 1 week from now. Thanks for coming, guys. Take care. Bye bye.